Christine, whenever you're ready.
Oh, hi, welcome everyone. Thanks for joining us for today's session on telemedicine clinical specialties. I'm happy to be your host today, representing the New Mexico Telehealth Alliance. My name is Christine David. I serve as the secretary of the Alliance, and as well, I am the virtual care program manager at Presbyterian Healthcare Services. I do want to mention a few housekeeping items for today's webinar. Please note that it's recorded and it will be made available on our website after this session if you want to go back and review or would like to share with someone else later. If you don't wish to be recorded, please turn off your camera. Rename yourself as needed, which can be done in that top view button in the right-hand corner. Please introduce yourself in the chat with your name and organization. All attendees will be muted while the presenters are speaking. So please put your questions in the chat until the speakers have all presented, and we will make sure that they get answered. And later, feel free to unmute yourself to ask a question. Today, I am happy to be able to be joined by 3 specialty physicians at Presbyterian. The first is Dr. David Phelps, who is the medical director for PHS Urgent Care Services. Dr. Phelps has been the medical director of urgent care services at Presbyterian since 2014. He also supervises the drive-through testing locations and online visits for our organization. After moving to New Mexico, he found urgent care is the best imitation of the training rooms that he learned to enjoy during his fellowship. And his department is moving toward increasing video visits usage and integrating with TytoCare devices to expand those services, which he will be speaking about in a moment. Also, we have joining us Dr. Rina Patel Trujillo, DO and MBA at Presbyterian Medical Group in Espanola. Rita joined Presbyterian Medical Group in Espanola in late 2015, filling a void of endocrinology needs in northern New Mexico. She was involved in implementing and providing telemedicine for endocrinology to PMG regional clinics in Clovis and Tucumcari, New Mexico in 2018. In March of 2020, she accepted the position of medical director of Espanola PMG outpatient clinics, overseeing primary care, surgical specialties, and subspecialty care, expanding over 13 departments. The pandemic has allowed her the opportunity to participate in implementing telehealth for Presbyterian Medical Group at large. We also have joining us Dr. Randy Niederhoff, neonatologist at Presbyterian Hospital Neonatal ICU. He is a newborn intensive care specialist who is fully dedicated and experienced in the expert care and comfort of critically ill and premature infants and their families. And thank you to all of them for joining us today and sharing their expertise and how they're using telehealth in their various specialties. First of all, I will start with Dr. Phelps. He will be talking about the evolution of urgent care from a primarily in-person setting to evolving through telehealth offerings in asynchronous care, as well as video care with incorporating devices into that. And as well, we'll touch on how to do a physical exam through a telehealth visit. So Dr. Phelps.
Well, good, I guess afternoon technically at this point. So probably is easiest, I started as a family physician, training in Eastern North Carolina and trying to find ways to spread our touch over about 28 counties in Eastern North Carolina from our clinic in Greenville. From there, moved to Pittsburgh, where I did a sports medicine fellowship and had to learn how to support 3 different universities, a high school, women's professional football team, while moving around to various clinics and being in 12 clinics and 10 half days during every week, and how to cover the high school when I was at away games for football. So learning how to do telephone consults with other folks at the other end on various teams. So that sort of began to open my eyes to what remote care might feel like, not being able to be in the room. And part of that is also sort of thinking back to history. Somebody at a graduation gave me a book of Osler quotes from William Osler. In our first week in medical school, the listen to your patient, he is telling you the diagnosis was really emphasized. And the power of medical history, which we can absolutely do remotely over a phone or over video. Balance that against another Osler quote that one finger in the throat and one in the rectum makes a good diagnostician, something one cannot do over video. And so trying to find a way in my practice to balance those two ways of thinking, I guess. And so when I joined private practice in Oregon, balanced my time between primary care and orthopedics, and again, supporting teams and supporting athletic trainers and trying to stretch over a city from my office. Moving here, primary care didn't fit because it was much more chronic disease management, and I actually missed the chaos of my previous life and doing many things at one time. And then I joined urgent care and quickly became the medical director there. Over the last 5 years or so, we have started the online visit program, which is an asynchronous healthcare program that was really invented, in this version of it anyway, by a group, Bright MD in Portland, Oregon. And how do we use asynchronous care without video in providing care to very low acuity patients with low risk treatments? Colds, rashes that we can have pictures of, and those kind of things. And now as COVID has hit, how do we stretch our team and continue to care for people where infection control has been highlighted? And then looking forward to how do we help serve rural parts of the state that don't have access to as much acute care, in making the decision whether an emergency room visit is necessary, or can this be handled virtually before they take an hour drive from wherever they are to the nearest healthcare? And I think one of the big issues that I've had and worries I've had with this is how much quality can you offer without a physical exam? In fellowship, and in a lot of those cases, I had an athletic trainer on the other end of the phone. I had a very experienced pair of hands that could do an exam for me and present findings. Then didn't really move into the smartphone and pictures at that point. But learning that it could be done, but now how much could I do relying on an untrained pair of hands, a family member or the patient themselves? And so that's where I'm struggling now as we move into video for urgent care, is how far, what patients can we select? Where can we maintain safety and the quality of our visits and be able to provide good care? And so I've been looking around for quite a while, and I'm gonna just paste an example, if I can, of, not looking like I can. Let me try this again. Of the types of things that one could, in theory, document. This is not going to work for me. In a video visit, general, right? Just the mood of the patient, the coloring of the patient, social determinants of health, where the patient is, the view of their house. I have treated a patient on video visit for hip pain who was driving around town, pulled over her car into a parking lot and did her video with her phone. So it was the ability to see her, okay, well, she's in a car, she's moving around, she's doing errands, she can squirm around in her seat pretty comfortably to do a physical exam. Not a great physical exam, but she could describe what hurts and touch things for me. Respiratory, speaking in full sentences, no coughing witnessed during the visit, breathing comfortably, no struggling. Cardiac exam, you can see coloring, ask the patient to check their own pulse, abdominal exam, jump up and down and try to get rebound out of somebody is at least possible. Bend and move around and you can get an idea if there's guarding. And ask the patient to do a physical exam and find out where the point of tenderness is. Could you specifically do a Murphy sign for a gallbladder? Probably not, but you can get a pretty good idea in a low acuity patient. Muscle skeletal, I think there's lots of things you can witness: range of motion, points of tenderness. The sports medicine doc in me is never going to be quite happy with doing an orthopedic exam, but you can get the basics of, does this need to come in? Or is this something we can brace, wait a week and see us in a regular clinic? So that's current state. And the thing we're looking at now, Presbyterian has signed a contract with a company called TytoCare that has a piece of equipment that you can buy at Best Buy, and it's a palm-sized device that can have an otoscope head and speculum fit onto it and give you a good ear exam that can be transmitted, give you a good throat exam, has a dermatoscope so you can see skin lesions very close, very tight focused. It has a stethoscope, and our cardiologists have been playing with this now, and I have not yet seen this one, but are telling me they can get as good a heart sounds and sometimes even better because you can control some of the audio details that you want, as if you're listening to your stereo from across town or when supporting a patient across the state. You can also hear lung sounds, and there's a Tyto Pro where you can Bluetooth in blood pressure cuffs and scales. And there's discussion with Tyto that they have used this in Dallas with pediatricians supporting school nurses, much like my experience supporting athletic trainers in various training rooms across the city. And so I'm looking at how do I, in my role, and then how do we as an organization and how do we as a healthcare system start utilizing more and more of these types of technologies to solve the problem of a rural Eastern North Carolina where I trained, an extremely rural New Mexico where I live now, and make a difference and solve some problems. And so that's just sort of a historical overview of sort of where I've come with this and the types of concerns I've had and the new tools and new hopes for the future. I think that's probably a reasonable start, and really wanted to kind of lead a discussion around this stuff and answer as many questions as I can. But I think I'll turn it back over to Christine, if that sounds good.
Thank you, Dr. Phelps. Appreciate you sharing that. And now we will go to Dr. Patel Trujillo, and she will share how they are using telehealth in her endocrinology practice.
Good afternoon, everyone. I wanted to kind of start with my experience with telehealth back in 2018. Being an endocrinologist in the state of New Mexico, resources are slim. There aren't very many endocrinologists. We have a high need for diabetes care. And so in 2018, I worked with some of our other regional facilities to see if we can do a telehealth setup where the patient would be at another facility, and then I would be able to do a video visit with that patient. The thing that I really like about endocrine is numbers, right? And so as long as I was able to get the patients to do their blood tests, their labs, they were able to bring in their glucometers or their meters, they were able to get them faxed to me. And we were able to kind of have a visit synchronously at the same time that way. And so we did that for a couple of years. And then when the pandemic hit, we tried to search for new platforms to be able to provide telehealth direct to consumers. And one of the platforms we ended up with was Doximity. And my work with my team is it's a very team-focused approach. So while I do the full scope of endocrine work, my staff helps to choose which patients are appropriate. So the clerical staff will ensure that these patients are able to have video and audio capability. Being in northern New Mexico and just in New Mexico in general, and having some of our internet connectivity issues was challenging. And then using my clinical staff to make sure that the patient is ready for the visit, that they've done their labs. On the day of the visit, they will room the patient, gather all their medications, their insulins, their hormone values for me. And then a really neat part of diabetes care is I do a lot of pump therapy and continuous glucose monitor therapy. And with the help of our representatives for these machines, we were able to get patients to upload from home. We were able to download that data here. And so I would have my reports of their pumps, of their continuous monitoring, of their labs, and we'd be able to have a great visit as if you were sitting right in front of me. And then I would be able to then talk the patient through how to make pump setting changes. And then to ensure that the patient did it correctly, we would then have them upload again, and we would download to ensure that they didn't miss it by a decimal point, which would be very important when we're manipulating insulin in a pump. And as telehealth has progressed, so has the technology in endocrine and diabetes care. So now we have various glucose monitors that patients are using, swiping their phones, and I can get that data to the cloud and down to me every day if I wanted to see them, because they're linked into the clinic database. And so, when I'm actually doing the visits, so initially we started doing visits on our cell phones, small screen. Eventually the platform also expanded their services, and now we can do video visits through desktop versions of this platform, which has been really nice. And not having to use our cell phones, our LTE, or our Wi-Fi on our phones, but using the network Wi-Fi. So improved connectivity for patients. And as we continue to get better and better, we added share features to the desktop version. So now I can pull up a thyroid nodule, I can pull up an adrenal mass, and I can show the patients what I'm seeing, what we're looking at, what we're talking about. I can show them their lab trends. We can now add family members to the conversation. It's an elderly patient, but the daughter has to be at work that day, and the caregiver can get the patient on the video, but then they will call in the daughter so that she's the main caregiver outside of working hours. And so we can have a nice comprehensive visit for the patient by being able to add family members. And then of course, we're able to now add interpretation services. So we're just expanding our coverage and our availability to reach patients all over with various, before where we felt that we were limited, we have conquered those, barriers. And then finally, after the visit is done, particularly in my clinic, I usually type, as I'm doing their visits, I'm typing their summary, their insulin changes, their titrations, their next labs, their next whatever. And then once we are done with the visit, my staff is then printing it and sending a copy so that they have their instructions as if they would had they come and see me in clinic. And what's great about our electronic medical record is now this aftercare summary is then posted onto their MyChart, which is fantastic, and they can just log in and see that and don't have to wait 3, 4, 5 days for them to receive their aftercare summary in the mail. Right now, I do approximately 30 to 50% video visits throughout my clinic days. We really allow patient preference to be, if they want it, we will try to figure out how to get it for them. And then, of course, patients who want to come in, it's always a pleasure to see our patients in person. You know, we miss that. We are hands-on providers, so that's also nice. So that's kind of my experience through endocrine. There's other than, you know, talk about the physical exam, even my biggest physical exam is probably my thyroid nodules. And we've even been able to, even in our meetings that are non-medical, people have pointed out, hey, I see something on your neck. You might want to get that checked out, you know, and it's teaching the patient to help you with their exam, and we've learned how to help them help us basically in their physical exam. So I know this was a broad overview, but I'm going to go ahead and stop here and take any questions at the end if there are.
I will ask, or we do have one question for you, Dr. Patel, before I turn it to Dr. Niederhoff. Are you finding seniors are getting more comfortable with video visits? Has this evolved since the outset of COVID?
I think they are. My average age in my clinic is mid to late 60s, just because of the population that I see up here. And I think they're scared initially just because it's technology. And then as my staff, my clerical staff, as they're making that appointment, they're teaching them. As my nurse calls them, they're telling them, it's just going to be a text message. Are you able to get a text? Mm-hmm. Yes. Well, in that text message, there'll be a link. But what's a link? A link is going to be words that are going to be in a little bit of a different color. Press that color. Press those colored words, and then it'll show up. And as we work with different phones, right? The iOS and the Android, we found challenges that iOS was much easier to connect audio video with, and the Android and the Samsungs were a little bit more challenging. Many of those asked the patient to allow microphone or camera access, and then you had to go back into the settings and figure out how to help them to get through that. So there was a lot of technology learning on my end, and then I have to teach the patient how to do that, you know. And in other clinics, we've gotten our staff to help us with some of that work. Let's what type of phone do you have? Let's be prepared. Let's be ready. And so as my patients now, how easy it was to touch the link and it connected within seconds, we were able to have this visit. They feel more and more comfortable about having a video visit, and especially in the winter and traveling sometimes several hours to get here to have their endocrine work. They're getting more and more comfortable to answer the question.
Great. Thank you. We might have some more questions at the end for you, Dr. Patel. But now I will turn it over to Dr. Randy Niederhoff, who will talk about how he is using telehealth in his neonatology practice.
Thank you, Lori, Christine, and Lisa for giving me the opportunity to talk today. And thank you all for giving me your time and attention. Let me just get things squared away here and we'll get started. Okay, my aim today is just to describe to you briefly what neonatology consultation looks like using telehealth. First of all, I do oversee care of babies at the Presbyterian Newborn Intensive Care Hospital. Newborn Intensive Care Unit at Presbyterian Hospital. It is a high intensity NICU, 60 beds. There are 8 of me, 8 neonatologists, and 8 neonatal nurse practitioners, about 130 bedside nurses that are neonatal trained and expert in what they do. And we have a robust ancillary services that are dedicated to the newborns, pharmacy, respiratory therapy, occupational therapy, speech, social work, care coordination. We're one of 3 newborn intensive care units in New Mexico. All 3 of our units are in the Albuquerque metro area. So you can imagine that there are many babies born at other facilities who don't have direct physical access to our NICUs and yet have babies in distress. And so telemedicine is a tool that we use to extend ourselves. Telemedicine consultation in the NICU is an on-demand service. It's when the baby and when the care team at the outlying facility need us. And as neonatologists, our aim is to be a support for the less experienced clinical team in the midst of caring for that critically ill newborn. We've been doing this for a very long time through telephone. So telemedicine is just an extension of that service we've been providing for a long time. What's different about telemedicine is that we can see a lot of things in real time with the video. And of course, it's a secure connection and the video is of adequately high quality. We can observe that distressed newborn, and then we have a clinical discussion, not just one-on-one with the provider, but with the whole clinical team there through the telemedicine cart. Then this service is not just for transport of babies to our NICU. That does happen, but just as often we want to help the team that's there at the birth hospital to continue to take care of that baby with good quality and help the baby's distress. Here are listed clinical indications for telemedicine, for NICU telemedicine. The first two indications by far and away are used most often. Babies that are born around their due date, they're born at term, are sometimes unexpectedly in distress, having physiologic instability. And that's one common indication for a NICU consult. And then babies who are born prematurely routinely need some added support, not just regular newborn care. So another common reason for a NICU consult. And then listed here also, we can have the telemedicine card in the delivery room when there's an expected to be a complicated delivery. We don't, as neonatologists, help with the delivery per se, but the baby that's born right afterwards often needs resuscitation, and we can be there for that through telemedicine. Sometimes a baby has just an unusual physical finding that we need to look at, or an unusual behavior. Common or typical things for behavior would be seizures or opiate withdrawal. And although we don't do this currently, we certainly could round on a daily basis on lower intensity newborns, babies that are requiring some specialty care at the outlying facility that just need a daily check-in to see how they're doing. This gives an idea of how often we're using telemedicine. We, as neonatologists at Presbyterian NICU, take about 400 calls annually from providers who are taking care of a newborn in distress in the moment. Some of those, sometimes we get more than one call for a newborn, so that overall there's about 300 unique newborns. About half of those newborns are born at sites that we currently do not have telemedicine capabilities, and then half are born at sites that do have telemedicine capabilities with us. It's not appropriate for all newborns that are in distress to have a telemedicine consultation. Sometimes it's just a real quick question, a simple question that can be answered easily over the phone. And that's currently about 70% of the time that happens. And about 30% of the time we do connect through a video consultation. Our target, our self-imposed target for our practice is 40%. We do get to that some months, but we think we can use telemedicine effectively about 40% of the time when we're being called about a newborn in distress. This just is the list of steps to take to get a NICU consult going. It looks long, but all of that can be accomplished in about 5 minutes from the time the provider or nurse or unit clerk at the birth hospital calls the NICU at Presbyterian Hospital to the time the neonatologist actually gets connected with a video conference, that all takes about 5 minutes, and the steps are listed here. We can talk about that more if you like. My role as a neonatologist during a NICU consultation is to observe the newborn. What's the baby's respiratory pattern? Is he having retractions? Is he breathing fast? Is he having a grunting pattern? What's his skin color? Is he pink all around, or his hands and feet blue? Is he pale? What's his muscle tone like? His activity like? And then we can also look at the real-time cardiorespiratory monitor that has heart rate, oxygen saturation, and respiratory pattern on it. And then we can also see what kind of support the baby's currently getting, particularly the respiratory support. A common thing we would hear when we're using telephone alone is that the provider would tell me the baby's on a CPAP of 6. Well, that can mean a lot of things. Through video, I can see what the patient interface is. For example, is it just a simple nasal cannula? Is it a RAM cannula? Is it a Vapotherm cannula? Are they nasal prongs? What type of nasal prongs, Hudson, Fisher-Paykel, or otherwise? All of those different patient interfaces give a different kind of CPAP. And then a CPAP of 6, what is the pressure generator? Is it bubble or is it a ventilator? So you can imagine I can see a lot in a very quick time what kind of CPAP that baby's on if I have a video. And then there's a discussion that we have, just again, with all the clinicians involved at the bedside. We review the baby's course and review labs and an x-ray if it's available. And then I'll give recommendations for ongoing clinical care and support. And when it's appropriate, when the need arises, I can arrange for a rapid transport to a higher level of care. One of the most fun things for me is to then, after we have the baby somewhat more stable, I ask one of the staff to roll the telemedicine card into the mom's room. Usually the mom and the baby are separate at this time if the baby's in distress. Roll the card into the mom's room, and then I can have a discussion with the mom and the extended family that's there about the baby's condition, usually giving them good reassurance and anyway, and answering questions that they might have. This is just for those people interested in the hardware. This is the telemedicine cart that we use at the birth hospitals. The left picture is a front view and the middle picture is a side view. There's really just 4 parts. There's a webcam on the top right, hooked to a tablet, and then a good quality microphone speaker device, and all that's mounted onto a rolling stand with a power source. We use Zoom as our video conferencing platform. And one of the great things about this setup is that I'm on the far end from the baby, have camera control. So I can use the wide angle webcam to zoom in within that wide angle to various areas of the view and get a very good close-up. I can also use the tablet's camera to get a bigger view of the whole team and the whole perspective. Often I'll see the cardiorespiratory monitor in that view as well. I hope that gives you a little bit of appreciation what NICU consultation is like through telemedicine. And I'll be happy to take questions during our discussion time. Thank you.
Thank you, Dr. Niederhoff. We do have one question for you in particular, and then I will circle back to some other questions that came through. But for you, what general percent of neonatology consults require a transport versus the newborn being able to be cared for and stay local?
It's roughly half. And it's hard to predict before you do the consultation or before you get connected through video conferencing which of those babies is going to require transfer and which are not. Sometimes it's obvious, but many times we just don't know. By saying a baby's in respiratory distress and they're on a CPAP of 6, I really have no idea whether that baby's going to need transport or not. But again, just to answer the question, generally about half.
Great, thank you. I will go back to a question for Dr. Phelps that came in earlier. Dr. Phelps, how do you see use cases for asynchronous versus virtual video care differ? And what patient demographic do you see most gravitates toward virtual care?
So I think there's, if I look at asynchronous, synchronous, and then even in person, few differences pop up very quickly. Our asynchronous team, how do I put this? Some sales pitch rep person was trying to sell an EMR at one point, and they asked, who's the cheapest person to document that you can hire? And the answer was the patient. And so I think that the asynchronous visit, you can, through that model, they're doing a ton of the documentation, a ton of the differentiation, and our time on task for our providers is about 2 minutes. So from an access perspective, those providers can be hugely productive. When we look at a surge like this and our press now in EDs being overwhelmed, we can magnify our impact in an underserved state with a technology like asynchronous visits. Synchronous and video visits, it's pretty much equivalent to an in-person visit. There's still a conversation, there's still the oh by the ways, there's still rapport building, there's all those pieces. And then even though you're not doing as complete an exam, you're still having to do an exam in kind of a weird way. So it winds up being about the same from a time standpoint as in person. So there's a magnifier in async. The patients that you can do in the async, very low acuity, safe problems with safe solutions, and really good guideline based. So you've got a Centaur score for strep throat. If on the online visits, they do a self-exam and their Centaur score is 0, really comfortable not worrying about strep throat and setting that aside. If their Centaur score is 5, I'm pretty comfortable thinking 70% chance of strep is probably strep, and I'll give some antibiotics. And in the middle, I'll refer them up for a test. For async, we eliminate very young, we eliminate old, we eliminate immune suppressed and cancer and high risk and a bunch of comorbidities. I think on synchronous visits, I can talk through those a little bit longer with patients and have more of an informed consent about, I'm gonna treat it this time, but I'm concerned about this, and I want you to have a much lower threshold to come in. So there's sort of the super low acuity to low, maybe medium acuity, and the comorbidity question. And the last one I think we've really run into is a compliance that's a difference. With the asynchronous, there are lots of folks who will get on to that cold module with 2 days of stuffy nose, demanding antibiotics for their sinus infections, which is simply not appropriate. Be told that they have a cold, get angry, write a complaint, and go somewhere else to try to talk them in, talk the next provider into antibiotics. Where I think on video and in person, my antibiotic utilization is pretty low. And I can really talk through why that's true and educate about how to use healthcare, how to use me in the future, and even self-care in a way that I'm not sure I'm as comfortable that asynchronous visits does well. So those are kind of the compare and contrast of the three. And somebody else had a question I saw in the chat about how do you chart. Asynchronous visits essentially generates its own chart. It suggests a likely diagnosis, but we can change that, prescribe meds, and it becomes its own independent record that then essentially gets scanned into our EMR. And video and in-person, for us anyway, are using exactly the same tools in Epic, whether it's over a screen but I'm typing in the same kind of note. So to answer my part of both of those. Does that help, Sharon?
Yeah. Sharon, did you have any further questions on what Dr. Phelps
I thought that was
answered?
excellent. I thought it's fascinating for me to see how we've evolved, and then to be able to, I know our urgent care is becoming more and more adept at video, and it's been a while, Dr. Phelps, since we've had a chance to chat. And so to really hear those reflections is terrific. I did not know, switching gears to Dr. Niederhoff, that 50% of patients are able to stay local. You know, those babies don't have to be transported. I mean, I think that is fascinating statistic. And so, sorry to jump around. Go ahead.
So let me circle back to the integration into the health record. Dr. Phelps, you touched on that. Dr. Niederhoff and Dr. Patel, do you want to add anything into how your encounters integrate into the EHR, and do you use specific formats for that documentation?
For the NICU, we have templates set up, telemedicine templates set up, and essentially there's 4, and we use them regularly, and we're able to track them very nicely through Epic. And so that's been a great help for us to both standardize our documentation and to track our activity.
Dr. Patel, would you add anything?
The only thing I would add is there is a header that we do put on our outpatient visits that kind of tells where the patient is, where the provider is, consent to have a video visit, part of just being able to bill for video visits.
Great. Thank you. And then another question for the panel. What factors do you see influence provider adoption of telehealth? How can we better help and support providers in becoming more comfortable with virtual care? Dr. Patel, would you want to start?
Sure. I think in the beginning, there were a lot of challenges. It was new technology for the provider, for the patient. And as we have evolved and ironed out so many of those issues, I think providers, at least in my facility, are open to doing it. Some providers are actually doing it 50-75% of the time, and others are probably slow adapters. And I think, as with everything we're dealing with COVID, you know, having your staff, your team help you make this visit successful is a big part of being successful as an outpatient provider for video care. And then when you don't have great IT support, or if something's not working, you know, being able to call that person and they be on site and help you right away makes the difference in whether the provider will then continue or want to do more video visits. You know, so I think those are some of the challenges. But overall, I think as things have gotten better, more people are open to doing it.
Great. What about you, Dr. Phelps, in the urgent care setting? What kind of providers do you feel, you know, really embrace the telehealth offerings, and what can be done to help support that?
Younger. We have a few providers who are in the I'm just not interested. It just doesn't feel fun. I've been doing it this way for a long time and I don't want to play. A lot of folks who've, you know, coming out of residency fairly recently have done something in this realm, particularly if they've just graduated during COVID, for sure. You know, for our asynchronous team and a lot of people who are very interested in video, it's been a nice diversity increase for us. I have a whole lot of moms of young little ones, and me as a dad of fairly young little ones, that really appreciate doing an asynchronous video or an asynchronous video visit anyway from poolside. When my kids are swimming and I'm hanging out at practice or a meet, I can still, in essence, be working, just, you know, distracted by my phone buzzing a lot. And so I think there's a growing group that gets a feel for it. And then I do think it's just force some folks to do it once or twice, and they realize, okay, I don't have to do every visit like this, and I don't have to finish this visit that starts like this. I can transfer 50% of these kids to my NICU if I need to. I can tell 30% of our online visits that they need to be on video or they need to come in. We can't care for every single case here. But I can get started and I can tell them, here's why you need to make that drive. So I think it's getting that confidence that, you know, yes, you can transfer to the emergency room from our clinics. You can transfer to here from a video. And that's been helpful for those that are a little bit resistant.
Okay. Dr. Niederhoff, do you have anything to add about your providers and their embrace of telehealth and neonatology?
It's been difficult to find anything good about COVID, but I will say that video conferencing has become, you know, a common thing during this time. So in that sense, COVID's been a help to telemedicine for us. We started telemedicine in early 2019, and you know, it was just a starting program, and we had some struggles, but COVID actually helped us help people feel more comfortable with video conferencing. I would say the obstacle, the barrier still getting started with any particular provider group or birth hospital is just getting a NICU consult started. That 5-minute process I described seems like 4.5 minutes too long for most people. But you know, once we do that a few times and it becomes smoother, and people understand the yield of a video consult, they quickly take it and like it.
Thank you. The next question is, so many specialists rely on imaging to provide comprehensive consultation. What barriers are you experiencing to image sharing? Would you like to start, Dr. Niederhoff?
Sure. For the Presbyterian regional hospitals, we're able to see all of the images they're able to see at those hospitals through the medical record without telehealth. I can view a plain chest x-ray, for example, which is the most common thing that we would want to see on a baby, through the Epic medical record. For outlying places, it's not as easy, but through the CART, we would be able to share screen on their end, and I would be able to see if they had their x-ray pulled up on the CART. If they were logged into their medical record on that CART, I could see that x-ray very nicely that way. That would be the probably best way to do it if we weren't sharing medical records.
Thank you. Dr. Phelps, how about you? Are you having any barriers with the image sharing?
For us, there's, I mean, if I'm talking to a patient, I don't expect any images with an individual at their home. So that's, for us, you know, for text technology, can I see well? Can we hear well? Is video going? So far, it's been pretty smooth. I haven't had any big connection problems. We're mainly based in Albuquerque, and connectivity is pretty straightforward for most of our folks. Those that have a device that can do this usually have connection enough to get good video, good sound.
Great. And Dr. Patel, any barriers that you're experiencing with image sharing?
Not really with the platform. With Doximity, I can share my screen and pull up their image to share with the patient. And I'm hardwired into the network in the facility, so that makes it easy. The only challenge I have sometimes is if the patient is in the Walmart parking lot and their connectivity is not very good, then I can't see them. They can see me, maybe. But those are the only barriers to connectivity. And as far as image sharing, after they added that tool, it's been great.
Great, thank you. I think we have covered the questions in the chat. Oh, I'm sorry. No, we have another. So what would each of you like to see improve with telehealth? The tools, patient education, provider education, or other? And we can start with you, Dr. Patel.
You know, working with Sharon and her team, many of these things have been discussed. For example, the providers kept saying, I'm not an IT person. I need help figuring out how to get the patient to connect from home. And so their team helped make a flyer or a, steps to take. And those can be put onto my chart and mailed to the patient in advance. The patient can go into the visit and try to make sure that their phone is working. It tells them what steps they need to do to make sure they're connected correctly. So I think the team has made significant progress from the connectivity part, because that's what we kept hearing from providers is, I'm not IT. I can't, I don't want to do this. I'm not IT. And so that was great for the patient and provider education part, both sides.
Thank you. Dr. Niederhoff, how about you?
I would mirror what Rena said in many ways. I think once we get started with particular providers and clinicians, they get very used to it quickly, but just that initial getting used to it is the hard part, and getting connected well and not being intimidated by it. It just takes some time.
Thank you. And then lastly, Dr. Phelps, what would you like to see improved?
Just ran for pumpkin bread, some of the eyebrow. So, as I alluded to earlier, we're looking at this Tyto Care. And one possibility that I've seen with that is flipping the Minute Clinic kind of on its head. Instead of putting providers out in, either a Walgreens or rural, you could put my athletic trainers or nurses with centralized providers covering multiple locations. So I'm looking at how can you do that? And Tyto Care, anything you can Bluetooth, you can send through that device. So the more scale, vital sign materials, point of care testing that could be done portably allows one of our urgent cares to cover anywhere in New Mexico. At a conference I was at, that somebody's using Tyto Care in Brazil with city-based physicians covering rural communities without any access to healthcare. And so the dream part of my brain is, how do you do that? How do you centralize our providers and use less expensive, maybe more recruitable people to smaller communities that can't support either even a primary care provider or certainly a specialist? And how do we magnify our impact and reach? I'm an ECHO facilitator for our wellness and burnout. And so using technology to teach, I'll be teaching relation-centered communication on this format on Friday. And so educationally, this is interesting. How could you, as a primary care doctor, certainly Dr. Patel, I've always wondered, how do you do diabetic education, and why are you doing it one-on-one? And can I get a nutritionist to do this in mass as a support group / education? A physical therapist doing back pain, a simple back class in prevention or early treatment and triage. Why are we, you don't just hire a trainer one-on-one each time, you can do a group class. And how do we magnify our providers in a very understaffed state? And so I think Tyto Care is the first step. And I'm dreaming right now as I figure this thing out about how much can I stretch that to other things. Our comprehensive care folks are looking at wiring folks home. There is an ability to wire up an elderly patient's home and send an alert to the electronic medical record if they don't flush their toilet enough times a day, or they flush it too many times a day. You usually go to the bathroom 3 times, it's been 6 times a day. I think you have a UTI, somebody's gonna come out and dip your urine at your home. And preventing a potential ER visit or hospitalization. You haven't opened your door and you always walk your dog. Why isn't your door open yet today? What's going on? Have you fallen? Is there somebody we should call? So how do we use these kind of devices? Early warning, early treatment, early intervention, and then group. How do you use these to address group treatment, group education? So those are my pipe dreams, and I don't know exactly which of those comes first, but my head is swimming. So
Thank you. Lisa and Lori, I don't know what time we need to wrap up. Do we have time for another question? Okay.
Yeah, let's go ahead.
There was a question that came in on, have we faced any challenges with deaf, blind, or limited English speaking patients? Dr. Phelps, in the urgent care setting, have you faced challenges with that?
I don't know of any specific cases. And I don't know if that's because the patients are self-selecting. Again, my only concern so far is we're not accessible via this route for folks who don't have the finances to have internet or a cell phone. We may just simply be self-selecting in ways we're not even aware of against patients with language barriers, equipment barriers, or sensory issues. I think we're probably blind to that at this point. We don't see what we're not taking care of because they don't even try yet. And that's a worry I haven't been able to think through in depth yet, but it's something.
Yeah, good point. Thank you.
To add to that, from in a smaller community, when we know our patients and their family members, and as long as the family member is able to help a patient with a disability, and as long as the patient is with them on the telephone visit, that's how we have overcome those challenges. So I have a couple of deaf patients, and then with the Spanish speaking, we can integrate. We can call in an interpreter, so or any languages at this point, and so that's been really nice for outpatient.
How about Dr. Niederhoff? What is your experience with those types of challenges?
We haven't really experienced those challenges that we're aware of.
Thank you. I don't see any more questions in the chat. Is there anyone that would like to ask anything else? We're about to wrap up, I believe.
Mhm.
Not seeing anything else come through, but thank you so much. I really appreciate the time of our panelists and sharing all their knowledge with us today. And thank you to all of those who have attended.
Thank you. Thank you for an excellent discussion and great information. It's really dynamic. Thank you.